Yes. Hello, welcome everyone to the newborn care seminars. Um, Notices about our talks are available on our social media groups, WhatsApp, WeChat. We are progressing to completing the OneDrive, where you can access all our talks, past talks more freely, because I think the Dropbox is not opening on the work computers. RACP and the Australian College of Nursing accept self-declaration of attendance for 1 hour of CPD points. Um, you can now email Kurt or myself or Karen or Julie if you wish to be added on the social media groups. We can also forward all the invites. We have moved on to the Teams link from the talk from today. I think will be more accessible to the Australian crowd plus a crowd from overseas. Um, Please ensure you're muted at all times, except, of course, when you want to ask a question or comment. We will have 10 to 15 minutes at the end of the talk for Q&A. Please use the reaction button to raise your hand or use the chat box by writing your name so we know you wish to ask a question, or just type in a question in the chat box and we'll try to get to as many of them as possible. Just one moment. Over to you, Kurt.
All right, thanks, Rahul, and thanks everybody for joining again on these Sydney Uni webinars. And it's my great pleasure to introduce EBELYNE STAUB. She's a neonatologist from the North Shore Hospital, and she will present on the kidney, the forgotten organ, we tell it. She did a lot of work. So she originally from Switzerland, came here to Australia and did quite a lot of work on kidney. I think it's less forgotten nowadays, certainly after all the Awaken sort of papers which we've been showered, which I think is an excellent start to start thinking more about the kidney. So EBELYNE, over to you.
Thank you very much, Kurt, for the kind introduction, also for the opportunity to present. This is a great honor, and I hope I can share some of the insights and my interest, particularly in this topic. Let me try pull this up. That's the wrong way around.
Yeah, you got a good now.
Yeah. Okay. Right. Kurt is quite right in saying that it becomes slightly less forgotten. So when I started talking about the kidneys a few years ago, even it was indeed true that people weren't thinking all that much about the kidneys, but and that is sort of evidenced by just a quick and dirty PubMed search. If you look at these graphs of publications per year on development of particular organs in preterm infants, it is not surprising that it is topped by the brain, followed relatively closely by the lungs, and the kidneys still somewhat suffer from an orphan kind of presence in the PubMed, but it is increasing, and that's encouraging. And my good friend Mary told me yesterday I should stop calling it the forgotten organ, because that's just not such a sad and pessimistic title. So I have decided I will start calling it something else. Sorry, it's not advancing here. Sorry, not quite sure. There you go. So I think I'm going to call this Kidney is the New Black, and make it a bit more sexy. And I'm all here for the merchandise as well. I think we need to start wearing these t-shirts as well. But what I'm going to do today is talk a little bit about normal anatomy, and I apologize to those who are already in depth and acquainted with the anatomy and might seem slightly pedestrian, but just as a setup for the rest of the talk. And then go into the kidney development, particularly after preterm birth, the kidney function, also particularly after preterm birth, and some thoughts and definitions and evidence around acute kidney injury in neonates. And then the last bit of the talk, concentrating on why this has long-term consequences for our preterm patient population and those suffering from AKI in the neonatal period. So again, starting quite pedestrian. The foundation for this and the anatomy of the kidneys, the paired organ on either side of the big abdominal vessels, capped by the adrenal glands, consisting of macroscopically the renal cortex and the renal medulla, and the great vessels that lead into the medulla and then spread out into the cortex. But really what we are interested mostly in is the subunit, the functional subunit of the kidneys, which is the nephron, consisting of a glomerulus, where there is a tuft of capillaries inside the Bowman's capsule attached to a quite long tubule, where a lot of the reabsorptive and secretory process is happening. So the nephron is the glomerulus and the tubule, and when we talk about nephrons, that's the functional unit of the kidneys that we refer to. Every one of the glomeruli or nephrons is fed by a small arteries coming out of the arcuate arteries that come up through in between the pyramids of the kidneys. Producing urine is a relatively mechanistic process. So the blood flows from the afferent arteriole through the tuft of capillaries inside the glomerulus and across the filtration membrane, where water and small particles are filtered. And larger particles, including the blood cells and plasma proteins, are not supposed to go through those small filtration holes. And then the blood leaves the glomerulus via the efferent arteriole. And that primitive filtrate then goes through this long tubule, initially convoluted, and then into the long loop of Henle, again, where a lot of exchange happens in terms of water, electrolytes, and other solutes. It then gets collected in the collecting duct. That then brings the urine into the renal pelvis and down into the bladder. In an adult, the renal blood flow is about 1 to 1.2 liters per minute. Of that, the glomerular filtrate is only like 90 to 120 mils per minute. And of that, only 1 mil per minute of urine is produced. Obviously, in neonates, those numbers are a lot lower, and we're going to go into that in a little bit. Now, if you bear with me, just going to talk you through the embryonic development of the kidneys, because that is quite interesting how the body actually goes through 2 stages before it settles on the definite form of the kidney. So the pronephros forms around the 4th week of embryological development. Then it degenerates again by about 5 or 6 weeks and never excretes filtered material to the outside. It's considered without function in most mammals. After that, from about 5 weeks, the mesonephros develops as an outbud from the nephrogenic cord that runs in parallel to the primitive gut cord. It's fed by capillaries from the aorta. It forms primitive glomeruli and actually does do some active filtration and has some excretory function. But eventually, what then forms the final what becomes the final kidney in gestational week 9 is the metanephros from an outpouching from the ureteric bud, and that then forms the ureter and the collecting system. Adjacent to that, a undifferentiated bit of mesoderm in contact with that ureteric bud starts to differentiate into the metanephric cap, and from there we then get a feeding capillary that forms the capillary tuft, the Bowman's capsule that connects to the collecting duct, and then the lengthening of that tube into the tubules. And by about week 11 or 12, this kidney starts to produce urine. So quite an arduous process to get there, and obviously there is many opportunities where this can go wrong. We're not going to go much into congenital kidney abnormalities, but you can appreciate what a complex process this is. Importantly, new nephrons only form to about 36 weeks of age, and after that, the number of nephrons is final. Nothing else is formed thereafter. So that's what a human being gets for the rest of their lives. And the youngest of those nephrons form in the outermost region of the cortex. So it's a centrifugal process with the youngest sitting right under the capsule. The number of nephrons is very closely associated with birth weight. And therefore, since low birth weight in about 80% of cases is associated with prematurity, that then ends up with a lower number of total nephrons. The study by Manalik was an autopsy study of about 30 to 40 preterm and term neonates, where they counted the nephrons, and it's a relatively linear relationship with birth weight. A study by Houston estimated that per kilogram increase in birth weight is about 250,000 nephrons formed. However, with a quite large interpersonal variability, also based on gender and on race. However, it's really important to remember that the smaller the patients that we look after, the less nephrons they have when they're born. And the problem obviously also is when they're born early, they only have a very limited potential to catch up on the nephrogenesis. We know from other autopsy studies that new nephrons only form for about 40 days after preterm birth, and that the catch-up nephrogenesis is a limited number. So they don't end up with a full complement of nephrons if they, as compared to as if they had stayed in utero. In addition to that, as we all know, they then get unwell after birth. They don't grow particularly well. They have acute kidney injury, and all of that accentuates the risk that they end up with a lower total nephron number going into the rest of their lives. Evidence from Megan Sutherland in Melbourne has shown that those new nephrons that do form after preterm birth tend to be more abnormal as well. So as you can appreciate, in this upper histological cut here, she found that the glomeruli have sort of these baggy Bowman capsules. They're a bit misshapen, and the overall nephrogenic zone is narrower. I had done some work in the United States on a preterm lamb model where we looked at the growth of the capillaries within the glomeruli after preterm birth of the lambs at the equivalent of about 28 weeks gestation. And what we found, so these here are gestational controls. What we found, you can appreciate how those brown dots that represent capillaries are a lot less abundant at term in a lamb born at the equivalent of 28 weeks compared to a gestational control that wasn't born early. And some of my work that I'm doing at the moment in the space of kidney development is looking at the growth of the capillaries or the small blood vessels within the cortex of the kidney. I'm going to talk about this a little bit later, but essentially what we think we're seeing as well is that there are less of those small blood vessels that feed into individual nephrons in these low flow Doppler ultrasound images. So in summary, for the kidney development, we see that the number of nephrons is final at 36 weeks. Nothing happens thereafter in terms of nephrogenesis, and preterm infants and those small for gestational age are born with less nephrons, and they only have a limited capacity to catch up on their nephrogenesis. So they're set up with a disadvantage already. Now, before birth, there is a good amount of urine production. The numbers that are published showed a quite wide variation about the hourly rate of fetal urine production. This is a summary of many of these studies, and it estimates that somewhere between 3 and 20 mils per kilo per hour of urine are produced at the end of pregnancy. That's a really large range, and it's not quite clear why the studies disagree with each other, but what we do know is that there is definitely a solid urine production happening up to term. The placenta is the perfect dialysis membrane for the kidney. So if we were to measure fecal plasma creatinine and compare it with a maternal blood sample taken at the same time, the creatinine levels would be absolutely matching between the two. So in utero, the baby will not have decreased kidney function unless the mother has decreased function as well. Then at the time of birth, after cutting the umbilical cord, there's many things that happen, as we all know, in the tradition of the circulation. In terms of the kidneys, the renal blood flow increases quite a bit, although it is not particularly fast. So in utero, about 2 to 4% of the cardiac output goes to the kidneys. Within about a day, that increases to only about 6% and only about 10% within a week. And at 6 weeks of age, we reach something close to 20%, but not quite adult level. that is about 20 to 25% of the cardiac output that goes to the kidney. This is mainly due because of a fall in vascular resistance, very much the way we see it happening in the lungs. It obviously also happens elsewhere, including the kidneys, and with that, an increase in the renal blood flow. And that is then reflected in a slow decline in the serum creatinine over the first few days and weeks. We measure the throughput of blood through the kidneys by way of glomerular filtration rate, GFR. That is the volume of blood passing through the glomeruli and filtered every minute. It is usually expressed as milliliters per minute per 1.73 meters squares. The 1.73 meters squares came from the original GFR calculations, and what does it aims to normalize the GFR for sort of an average body surface area and make it comparable between different body shapes and sizes. It is in no way or shape perfect. It comes from studies that are over 50 years old that thought that the average male was 170 centimeters tall and 63 kilograms in weight, and that obviously is no longer the case. So today it should more be something like 1.93 meters square, but everyone is sticking to the 1.73. And it is probably also not doing the babies any justice, but at the moment that's all we have and that we use. So the GFR is a function of the number, obviously, of glomeruli slash nephrons. So the lesser they are, the lesser the filtration rate will be. Obviously, with the caveat that the body has some capacity to increase individual glomerular filtration to compensate for that. It depends on the maturation of glomeruli. We know that there is growth of the blood vessels in the glomeruli after birth, and because there's an increased demand, increased blood flow, and that then increases in itself the surface available for filtration. And as we've said, it also depends on vascular resistance. I actually couldn't find a vascular resistance image for renal blood flow. I'm actually not sure whether it has ever been done. We'll just assume that's the case in the kidneys as well. Over here is again a study that we did on the lands University of Utah in Salt Lake City, where we measured the surface density of the glomerular capillaries in utero. So that's up to here, this dark gray bar, and this next one here is 3 weeks after term birth, and it is quite obvious that the surface density of glomerular capillaries increases quite exponentially in these first three weeks of life, because there is so much more blood flow that then triggers in sort of the branching and lengthening of the capillaries. The glomerular filtration rate then increases slowly after the first in the first 3 weeks, as we've just seen based on these factors, but it only reaches adult levels after about 2 years of age. We use serum creatinine as a proxy for an estimation of GFR, usually by way of the Schwartz formula. Serum creatinine was chosen because it was initially thought to be the perfect marker for this, because it is filtrated freely across the filtration membrane in the glomeruli, and then goes through the tubular apparatus without being reabsorbed and without being secreted. That's not entirely true, but despite lots and lots of research into other markers that might better estimate the glomerular filtration rate, the vast majority of the world is still sticking to creatinine. The glomerular filtration rate in a normal kidney healthy adult is around 100 mils per minute per 1.73 meters squares. And you can appreciate how a term neonate with a normal weight, with no acute problems, starts off at a much, much lower rate at around 20 mils per minute per 1.73 meters squares. For an adult, that would be end-stage renal disease type GFR, but it is perfectly normal for a term neonate. And you can appreciate how over the first weeks of life, this slowly increases. And by 4 weeks of age, we reached about, roughly half of an adult GFR. The Schwartz formula was developed to have an easy way of calculating GFR rather than using cumbersome infusion studies of similar compounds that are freely filtered and not reabsorbed nor secreted, mainly inulin or iohexol. The constant 0.45 or 0.33 for preterm babies is meant to reflect the body mass and the muscle mass of the patient affected. It probably overestimates the GFR, the real GFR, particularly in smaller babies. However, if we disregard that, we know that in preterm babies, this adaptation, this slow increase in GFR starts at a lower point. So these are different gestational ages, starting with 27 weeks down here and 31 weeks up here. And the red dots superimposed from the previous slide that you've just seen for term babies. So babies as small as 27 weeks start off with a GFR that is roughly about 12 to 13. So even lower and increases slower than it does in term babies, and similarly with all the gestations of preterm babies. And that explains why the serum creatinine, which again here with the red dots for the term babies, decreases slower in preterm infants. You will now ask, what about this bit here, right? We all know that we see in our, particularly the extremely low gestational age infants, that in the first few days of life, the creatinine actually rises, despite often there being no other evidence that this baby is suffering from an acute kidney injury problem, with relatively good urine output and nothing else that's untoward. And there has been lots of head scratching over the last decade as to why that is. I think to start with, we need to ask ourselves where creatinine is actually coming from. Creatinine is produced initially actually in the kidneys. It's put together from the amino acids arginine and glycine into GAA, which is guaninoacetic acid, then gets transported into the liver, where it's methylated and then is deposited in the muscles as an energy store in a phosphorylated form. The creatinine kinase then transforms the phosphocreatinine into creatinine, hence producing ATP in the process, and the creatinine then is transformed into creatinine and excreted through the kidneys, which means that gentlemen like this here will have a quite high creatinine without having a problem with their kidney, just by the sheer fact that there is a lot of muscle mass. So apparently Arnold Schwarzenegger in his top form, as we see him here in all his glory, apparently it ran a creatinine of about 150 on a normal day. However, we're dealing with this sort of population. They have not much muscle mass at all. Hence, the increase in creatinine obviously cannot come from an increased production in the muscle. In 1999, Jean-Pierre Guignard published this paper here. Jean-Pierre Guignard was a nephrologist in Switzerland. He was one of my first mentors and teachers in the realms of neonatal kidney. Unfortunately, it's passed away a few years ago. And he had been wondering why that was. And he did some experiments and injected some inulin into small babies and figured out that the inulin clearance is actually higher than the creatinine clearance. And from there, he deducted, okay, so there must be somewhere along the way where creatinine, we know it's freely filtered, so somewhere along the tubules, it must get reabsorbed back into the circulation. And he postulated that because the tight junctions between the tubular cells are not quite tight, aka they're leaky, some of the creatinine gets reabsorbed. And for quite some years, that was sort of the opinion that we had, that this is why the creatinine goes up. You know, by all the respect and admiration I have for Jean-Pierre, I don't actually think that makes a lot of sense, because it's leaky. Why would it just go one way and not the other? And there has been some newer theories on why the creatinine goes up, and that's been published coming from the Neonatal Kidney Collaborative by David Ashkenazi out of the University of Birmingham in Alabama, that there is a thing called fluid adjusted creatinine that accounts for the processes in the first few days of life, particularly for extremely low gestational infants, as to why it goes up. So they postulate that creatinine is not something that's just in the serum or in the plasma. It is actually distributed across all the bodily fluids and compartments. After birth, we all know that the majority of babies go through a volume contraction where they lose water through the transepidermal route. However, because the GFR is so low, as we just saw, there actually is not that much creatinine excretion. There also is not much production at all, but together with no excretion, a little bit of production, and a concentration of the body, that will then increase the serum creatinine, because at the end of the day, it's a concentration. It's micromoles per liter or milligram per deciliter if you're in the US. Vice versa, if there is fluid overload, we won't see that increase in serum creatinine, and probably see even a decrease, and we're all, happy. But in fact, that doesn't mean the baby doesn't have AKI. So they postulate that we should use a fluid-adjusted serum creatinine, where we account for the fluid balance in those first few days of life, particularly in the first week of life, and have proposed this formula where the serum creatinine is a factor of fluid balance, which is the daily weight minus the birth weight over birth weight, and the total body water, which for the sake of their publications, they have assumed to be 80% of the daily weight in milliliters. And this is what they have produced in their paper, where, again, the Americans use milligrams per deciliter rather than micromoles per liters that we commonly use in Australia and in Europe. Hence, the increase in serum creatinine on this scale doesn't look too dramatic, but you can appreciate how it starts off at like 0.8, 0.9 here and goes as high as 1.1, and that doesn't sound like much, but in fact is about 20 to 30 micromoles per liter. At the same time, we see the weight change, the decrease in weight, and on average, an extremely low birth weight infant loses between 10 and 15% of its initial birth weight. And if that's adjusted, serum creatinine is adjusted for this weight loss, we will get a relatively straight line in the fluid-adjusted serum creatinine. Tamara van Dongen, who is a very excellent pharmaceutical PhD student, where I worked previously in Basel in Switzerland, have taken all of that into account and thought, how about we save the neonatologists the cumbersome calculations of the fluid-adjusted creatinine, and we will develop a mathematical model that takes all of this into account, the loss of body weight, of body water, the gestational age, the ongoing production of creatinine, and the low initial GFR, and come up with some normative data as to what is normal. And on a cohort of about 150 extremely low birth weight infants in the NICU in Leuven in Belgium, they have produced these centile curves for individual gestational ages, for the serum creatinine concentration and the creatinine clearance. So that again, unfortunately, in milligrams per deciliter, but that can easily be converted in micromoles per liter. And rather than us calculating the fluid-adjusted creatinine, these can be used to figure out whether a baby is actually having a kidney problem or whether we just see the normal increase in creatinine due to the volume contraction. If you bear with me, we're going to come back to this in a second, because the definition of acute kidney injury is relatively cumbersome. It has been adjusted, particularly in that in the AWAKEN study that I'm going to talk about in a second, and it is based on either the serum creatinine rise or the urine output over 24 hours. It's not an and criterion, it's an or criterion. You can appreciate on this here that the stage 1 AKI is the rise of the serum creatinine by 0.3 milligrams per deciliter, which, as you can appreciate down here, is around 27 micromoles per liter in the SI units within 48 hours, or the increase of serum creatinine by 1.5 to 1.9 from the reference to lowest serum creatinine within the past 7 days, or the drop of urine output to less than 0.5. Now, this is, still, even with the fluid-adjusted serum creatinine, A bit of a cumbersome definition, but it's the best that we have at the moment. And most studies published these days use this definition for AKI. Before we go, we need to keep in mind that serum creatinine changes and urine output are often just indirect and late effects of kidney injury. They're not markers of the injury itself. Again, there is lots of research going into different biomarkers other than creatinine, but at the moment, what we're sticking to is creatinine. And the same group has now also published just a few months ago the evidence that actually this fluid adjustment can be used to improve the accuracy of AKI diagnosis, particularly in those extremely low gestational age babies, to tear apart who is actually undergoing AKI and who is just going through a normal increase in serum creatinine. This is one of their graphs where they show as a dashed line the uncorrected serum creatinine in the entire cohort, which was a secondary analysis of the PEANUT trial, the 920 infants that were randomized into prophylactic erythropoietin or placebo at less than 28 weeks. And they plotted, because it involves the daily weight and daily creatinine in that cohort, they plotted what it looks like when it's not corrected, and we see that, familiar, all too familiar increase in serum creatinine, and then fluid adjusted it in this solid line, and it is a much more, much more gentle slope and peak here, together with the fluid balance that is often the most negative, around 3 to 4 days of life. And they plotted the whole thing by gestational age group as well, with the darker colors here being the youngest group, again with the uncorrected going up and the corrected kind of staying quite stable over the first 2 weeks of life. They then looked at the diagnosis of AKI as per uncorrected and corrected creatinine. They found that if you use the uncorrected creatinine, about 23% of babies had diagnosis of AKI, but when fluid adjusted, that increased to almost 34%. So, and also about 30% switched stages of AKI, and generally with the adjusted creatinine going up a step in the stages of AKI. This is a more visual representation of this. So this is AKI on that left-hand side, unadjusted for fluid status, and on that right-hand side, it is fluid corrected AKI, and you appreciate that the proportion of babies without AKI gets smaller, and that is probably particularly because those that are fluid overloaded don't get this peak in creatinine that we normally see, and then hence we don't appreciate that they actually might be going through AKI. They also then found that when using the fluid corrected creatinine AKI diagnosis, they saw that these babies had a higher risk of longer ventilation, higher degrees of BPD, ended up with a longer hospital stay. And if you looked at just the uncorrected creatinine, there's then a proportion of babies that have those complications, and it's not clear why, but there is that association with AKI if it's correctly diagnosed. So it is of value to use the fluid adjusted AKI definition. Now, just going briefly through, obviously, the reasons why neonates may get AKI. There is the pre-renal component. If the blood, the kidney doesn't get enough blood, that can be any reason from dehydration to heart failure to blood loss and a decrease in neonatal renal blood flow. Any of those factors can end up in a renal injury, as in the parenchymal injury, but also perinatal asphyxia that can end up in acute tubular necrosis, nephrotoxic medication, septic shock, or renal vein and artery thrombosis. And then slightly less common, the post-renal injury with an obstruction that then impounds the urine and damages the kidneys, commonly as a malformation posterior urethral valves in little boys. There can also be neurogenic bladder, medication-related urinary retention if we don't notice it early enough, and fungal balls and kidney stones as some rarer reasons for that. And this is now the famous AWAKEN study that we've referred to a couple of times now. This was a retrospective data collection of 24 centers level 2 to 4 NICUs in the US, Australia, Canada, and India. They looked at medical records of babies admitted over a 3 months period and collected what has now turned out to be a treasure trove of data that we get lots of results from. And what they found was a significantly higher than previously assumed incidence of AKI. So historical papers quote 6 to 24%, and they found a 36% proportion with AKI. 14% of those just by the urine output definition, about a fifth as per serum creatinine definition, and 3% by both. And what's really important from this study is that they confirm that having a diagnosis of AKI increases the risk of mortality by 4 to 5, and that is adjusted for the most common factors. If we look at this part here a bit more closely, in the middle is the whole cohort of babies with about, so the smallest here in this grey sector, so 40% of babies less than 28 weeks. Then this blue sector here with the moderately preterm from 29 to less than 36 weeks, and the purple bit, which are the more than 36 weeks babies. In that smallest group, about half of babies, this orange sector here, have a diagnosis of AKI. Being moderately preterm is probably the best time to be born in relation to not getting AKI, because only 18% have a diagnosis of AKI. And then it increases again in the term population that is mostly attributable to diagnoses like HIE and AKI in that context. Out of there, as I said, have now been, I think it's close to 20 publications of analysis of the data coming out there. I'm just referring to one paper where they showed how there was an association between early caffeine administration and the decrease of risk in acute kidney injury in preterm babies, with quite, a impressive reduction in risk overall, and that includes the extremely preterm of less than 28 weeks and the slightly less preterm infants. And there's several potential mechanisms that could be behind that. Firstly, that all methylxanthines increase renal blood flow and GFR. They enhance sodium excretion. We know from all the study that substances like theophylline counteract hypoxia-induced renal hemodynamic changes and probably attenuates a lot of the oxidative stress that we see in acutely unwell infants. We could do a whole talk just on the effect of caffeine and other methylxanthines on kidneys. It's not for today. One of my colleagues, Alison Kent, has done a lot of work in this, for example. And there is increasing also studies looking at the administration of prophylactic methylxanthines in babies with asphyxia to prevent some of the AKI that we see in these babies. The AWAKEN study only included one Australian centre, which was Canberra, and compared to the other centres, the incidence of AKI in Canberra was a lot lower than in the American, Indian or Canadian centres. Which is why there is a thought that maybe we are hopefully just doing slightly better, but we don't know because we're not collecting that data systematically in ANZNN. So together with Alison Kent and Amanda Dyson from Canberra, we have embarked on replicating the AWAKEN study for our local context. So it's called the NeoCAN study. It's not a particularly sexy name, but it's all we could come up with. It's a neonatal acute kidney injury and nephrotoxin exposure in an Australian and New Zealand population. We have got 6 centres now that we're recruiting from, like it's a retrospective study, surgical and perinatal 6-month retrospective data from January to June 2019, and that was purposefully chosen to not have any conflicting influence of the pandemic that came between then and now. And we should be completing data collection by the end of this year. So very hopefully we'll be able to report on those results soon. So from a renal function perspective, the summary points are that despite not forming new nephrons after birth, glomeruli continue to mature and grow and hence increase their function. The blood flow through the kidneys increases with the physiological changes after birth, but it takes weeks and months to adjust to extrauterine life, and preterm infants make this transition even slower. Acute kidney injury is defined via an increase in serum creatinine and or reduced urine output, and using a fluid adjustment of serum creatinine is more likely to unveil AKI. We think that maybe up to a third of all our patients suffer from a form of reduced kidney function, but we're about to find out for the context of ANZ and importantly, the acute kidney injury increases the risk of morbidity and mortality independent of any other risk factor. Now, finishing off, I want to talk a little bit about the long-term implications. That is really something that one of the major factors why I'm so interested in finding about more about the neonatal kidney. Obviously, we've become a lot better in keeping babies alive in the last few decades. This is survival to neonatal discharge of different gestations from the mid-19s to the mid-10s of this century. And we can appreciate for the lower gestation of 23 weeks that we're now sitting, close to 50% when we started off with 20% in 1995, and obviously much higher for 24 and 25 weeks. And because these babies often then now go on and having lives that are relatively free of severe disability in the traditional sense, we start seeing how as young adults they suffer from consequences of their preterm birth that we're not previously acutely aware of. We now know from big population studies that adults born preterm, either low birth weight or growth restricted, do have a higher risk of albuminuria, a lower GFR, an overall higher risk of renal dysfunction, and end-stage kidney disease. These are studies that plot these risks. Is a study, an American study, looking at a cohort of young men that need dialysis for their end-stage kidney disease and relating it to the birth weight, with the birth weight between 3 and 4 kilos assumed to be the reference, with an adjusted odds ratio of 1.65 of those born less than 2.5 kilo to end up with end-stage renal disease. There's also this interesting bit here that when you're born large with gestational age, that seems to be a risk factor as well. I haven't even touched on that, but there is literally another side to that story. This graph here is from a large Norwegian database that looked at over 2 million children born between 1967 and 2003, of which a proportion developed end-stage renal disease, showing how being born early increases the cumulative risk of end-stage renal disease, more so in men than in women, but it is higher than average than in term-born babies. With that comes an increase in risk of arterial hypertension. Systolic blood pressure is between 2.5 to 4.2 millimeter mercury higher in adolescents and young adults compared to those born preterm, which seems a relatively small difference. But we know from large preventative studies for cardiovascular disease that a decrease of blood pressure by 5 millimeter mercury decreases the risk of stroke and heart disease by about 34%. So it is important, those small differences. There's an inverse relationship between gestational age and blood pressure, and obviously the younger at birth, the higher the blood pressure in adult years. And we think that the difference between someone born at 24 weeks and term is for men about 5 millimeter mercury and about 11 in women. There seems to be a gender, like a sex difference. That's not quite clear yet why. Why is that? It probably the best explanation so far we have is the so-called Bremer hypothesis. As we've seen, prematurity and low birth weight leads to a reduced number of nephrons, so-called oligonephropathy. Because the glomeruli are really good at adjusting at a higher demand, individually, because there are less of them, the glomeruli will start to hyperfiltrate. So they take over the work that other nephrons should have done, but that they're not there. And that over time leads to glomerular hypertension. It damages the glomeruli. They either get lost or they become sclerotic. So there's even less nephrons to work with. So those that remain need to work even harder. That is not a process that is fast. It takes several decades to really have an impact on kidney function. We need to lose about half of our nephrons until we start seeing it in various biomarkers that the kidney function is going off. But it then ends up with systemic hypertension, proteinuria, and can end up in chronic kidney disease. If you add to that an increased loss of nephrons through neonatal AKI, that increases the risk even more that there is going to be a problem later down the track. And there is several studies that now are showing this. For example, this is an abstract that talks about over 4,000 pediatric patients with AKI, of which about 720 were neonates that had AKI during their hospitalization that did not need dialysis. So it was, in the stage 1 or 2. And matched it with a cohort that did not have AKI, and 18% of those who had AKI developed chronic kidney disease in young adulthood, as opposed to 5% in those that did not have AKI. So prematurity in itself is not great. Add to that neonatal AKI, and it worsens the outcome. My focus of research is the research into what else is there rather than just the lower numbers of nephrons, and I'm working with a hypothesis that prematurity is some sort of anti-angiogenic state, so it impedes blood vessel growth. We know that from other areas, for example, the retina. So despite the risk of RFP and sometimes abnormal blood vessel growth, there has been reports that retinal vascularization is lower in children born preterm, so as evidenced by images here. And there's also a quite good body of literature showing that the skin capillary density after preterm birth in adulthood is lower, and that is associated with higher blood pressure. So it's kind of obvious to think that this might be happening in the kidneys as well. So the hypothesis of my PhD is that the development of microvasculature, the small blood vessels, in the kidneys is affected by preterm birth, and that then contributes to a risk of later arterial hypertension and chronic kidney disease. And the way we're examining this is by using what's called superb microvascular imaging, or other companies call it ultra low flow Doppler, and essentially we're using a very low flow Doppler signal to visualize really, really small blood vessels in the kidney cortex, as you can see here. So these blood vessels in the cortex are between 0.1 and 0.2 millimeters in diameter, and we aim to quantify the venocortical vascularity in that area, hoping to show that it is decreased in those born preterm. It's called the Diwali study. We've done a pilot, and this is some images from that pilot. This is a baby born at term, 3 days old, with these cortical blood vessels, and this is a baby born at 25 weeks at term equivalent age. And it's quite obvious that those blood vessels are a lot less abundant. We think there might be a decrease of about 30%, but even a 10% difference is probably enough to then have problems later in life. So, in summary, for the long-term kidney problems after preterm birth, we now are more acutely aware that low birth weight and low gestational age are important risk factors for high blood pressure and chronic kidney disease later in life. That is probably due to a compensation of the lower total nephron numbers that lead to hyperfiltration and eventually damage. And there may be a component of decreased kidney vascularization that might contribute to the later risk of chronic kidney disease. And acute kidney injury in the neonatal period make all of this even worse. Lastly, I just want to add this last slide where I want to stress that the long-term follow-up at the moment is not yet well established, particularly not in Australia. There is some work coming out of the US, the Neonatal Kidney Collaborative, that wants to form a more defined approach to this. Unfortunately, we've just seen a draft of the Australian neonatal standard for follow-up of Australian preterm infants that does not mention blood pressure or any form of assessment of kidney health in any way or shape. There is no uniform approach, and even asking individual nephrologists, there is more or less appetite to follow up these babies. And also there is a quite low awareness in GPs and family physicians to, screen growing young adult former preterm children for kidney problems. One of the problems is that they don't have access to birth data, so you don't specifically ask that 18-year-old patient that may or may not come to them anyway. They won't be aware of the risk, and that's despite this review published 10 years ago that it has stated, these are risk factors: prematurity, AKI, IOGR, that should prompt follow-up. So there is a lot of work to be done in that space. And I personally hope that the work that we're doing at the moment will contribute to increase the awareness of the importance of this follow-up. For those who want to have a look at other resources, I can highly recommend the Neonatal Kidney Collaborative. Our unit is a member of that, and anyone can become a member. Unfortunately, we don't have a nephrologist to go with it. They would like there to be pairs of neonatologists and nephrologists joining that collaborative. But if you enter babykidney.org into your browser, you'll get to their webpage. There's lots of resources, very good webinars that you can look at, and lots of research papers that are freely accessible on there. With that, I close, and I have now, since I've said, I usually have used this slide here to talk about don't forget the kidneys, but I think I'm now changing it to something like this here. Kidneys are really chic, and it's worthwhile thinking about them. They're the new black, and I'm delighted that we're able to spread the word and raise the awareness around neonatal kidney problems. And with that, I will end here, and hopefully we'll have time for some questions.
Thank you so much, Evelyn. This was a great overview about the kidneys, how they develop, how difficult it can be to assess them. And the black is maybe also a little bit of a black box, and particularly in the first sort of 10 days after life, and when it's difficult to measure. And then you went on how these effects are sometimes not just in the beginning, but they can just continue on long term. And because we have more survivors of preterm birth, we will have more problems for the nephrologist later on in life. And there's quite a lot of questions which we're going to go to. I want to ask one question though. In the Awaken and NeoCan situation of assessing the AKI and the definition, is daily weight a good strategy?
Whether it's good or not is tricky to say. It's one of the only ones we have to assess the fluid balance, but it is no way or shape perfect. Last week there was the Neonatal Kidney Collaborative had a webinar where there was a whole presentation dedicated to the assessment of fluid overload in preterm and term neonates and how tricky it can be, and that weight is all but a proxy, but it's probably one of the better proxies we have. We often use sodium in connection with that to see where we're at in terms of if you think about the low GFR and the limited excretion of anything in the first few days of life. I always harp on about how hyponatremia is very much not a loss of sodium in those first few days of life, because not much is going out the kidneys, but probably really also supporting the idea of fluid overload, particularly if there's no weight loss or there's even then weight gain. But at the moment, I can't think of anything that is going to give us the fluid status better than daily weight, unless you then resort to really sophisticated methods like body impedance and stuff like that. That is not practical in the small vulnerable babies.
All right, thank you. Srini has two questions, which is related to AKI and how we make our adjustments to our medications, which are used in the formulariums. Can we use the AKI definition to make adjustments?
There has been nothing published on this in the space, particularly of the extremely low gestational age infant. There is quite some body of evidence in pediatrics and the older population. To my knowledge, and I might be wrong, but to my knowledge, there is no paper that has ever spoken about how the how-to in terms of adjustment. But there, if we become aware that the baby might have AKI, it's definitely worth adjusting. And obviously, I have to also pay tribute to Srini and his group with the ANMF, that literally in every single drug monograph that we get through ANMF, there is a section on how to adjust if to adjust and how to adjust drugs to kidney function. And I think that can and should absolutely be used if we think a baby has AKI. But there is limited evidence to say that we have we change outcomes if we do that, but it seems to be common sense that we should do it if there is AKI.
Srini, you want to unmute yourself to
ask the question? Kurt. Evelyn, thanks very much. Excellent presentation. I think it's very important to note that we have our own experts within Australia, like yourself, Amanda, like we have Alison Kant, and emerging one Amber Siegel, like all interested in kidney disease. And we actually had a chat with Alison Kant a few weeks ago about, like renal dose adjustment, for our ANMF formulary. Is there a uniform definition that we can advise for the clinicians, and then they can use that as a, definition so that they can adjust the dose? So looks like Awaken study, probably the one that you have put in, that fluid restricted definition, fluid corrected, sorry.
Yeah.
Maybe we will get back to you and Alison Kent and see if we can incorporate that in our next version of ANMF. Dose adjustment, use that as the practical definition.
I think so. Look, for me, it is the first time this whole creatinine increase in the first few days of life has ever made sense. When I read this paper, I was, oh, okay, fine, that's now finally something that does make sense and that we can work with practically as well. Then that we can take into account when calculating, treatments, drug doses, stuff like that, and also understand whether there's actually AKI or not.
All right, there's quite a lot of comments congratulating you with an excellent talk. So even though it's chic, I think still people need to be known and be aware. Anke Rijmakers would really want to thank you and say that, look, we as neonatologists shouldn't forget that these long-term problems persist. And if there was severe AKI, we need to follow up these patients on the longer term, which I think is a very important message, which you brought as well. There's two particular questions which are related to your latest research, which was looking at these vessels and these microvessels in these preterm babies. And the questions are one from Joseph Taro about the associations between calcifications, and which we used to know as nephrocalcinosis, and the other how to quantifying this with this microflow imaging. Can you also use 3D images? That must be from Tim. It is from Tim. Yeah. All right.
Yeah, so nephrocalcinosis is a bit of a black/white box as well, I think. When I started training, and every baby would get ultrasounds looking for nephrocalcinosis, and then follow-up studies until it was gone, and then it fell out of fashion a little bit, and some people start doing it again. I've not looked at it specifically for a while, to be honest. When I had a look at the literatures, and that's probably like 5-6 years ago, it seemed that no one was particularly sure as to what it meant for the outcomes of the baby. I think we appreciate that obviously it's not normal to have calcification in the kidney. A lot of that would be iatrogenesis by the various medications that we use that increase calcium excretion, and that includes caffeine, but also diuretics. And at the moment, my stance is it's not great if you have it. Yes, we can ultrasound it until it's gone, but really what we should do is follow up these babies long term to make sure their kidneys are okay, because I think it's a sign that these kidneys are not happy and something has happened to them. That's sort of my very simplified stance on this. And I'm sorry, I don't have the latest and greatest literatures on that. In terms of the calculation for the vascularity, well, 3D ultrasound would be, we had looked at it when we sort of tried to develop the methods. It seems much harder to get standardized images with 3D ultrasound, which is why we have settled on a 2D with the low flow ultrasound Doppler, and we have a crew of ultrasonographers here now that are very good at it. And once we have results, it might be worthwhile going back to other methods. The good thing about the low flow Doppler that is increasingly included in the newer models of ultrasound machines and will be much more widely available. When we started the study 2 years ago here, we were by far the only ones having such a machine, and now there's multiple in the hospital and in other hospitals as well. So it more seems also practical if you want to devise something that is applicable more broadly than just a single center in the future. We thought that might be the method to go, but there's definitely others as well.
Well, thanks. It is 2 o'clock. This was a wonderful session, and thanks again for presenting for the Sydney Uni webinar. And next week there's another talk. It's 2 weeks, I think. 2 weeks away, there's another talk planned for us. So thank everybody for attending, and I hope to see you at our next event. Thanks, Evelyn.
Thank you very much.